faculty, present faculty. And when this morning in my sleepless nights, I went to the Kansas website, and I realized that the first Frymoyer lecturer I ever introduced was Mark Asher, who was a world-renowned spine surgeon from Kansas. And the anecdote is that he ran over a little bit, and the basic scientists from UVM came marching down the aisles, and they marched down and we marched out the other side. But it's our pleasure to have another Kansan to visit us today, and Elise is going to introduce him.
Thank you. So it's my pleasure to introduce Kim Templeton. Dr. Templeton is, in my opinion, a really excellent choice as a Frymoyer annual speaker. And the reason is because she embodies academic achievement in pretty much any way, any box that you'd like to check, in my opinion. Clinically, she trained at Rush and then UMass for musculoskeletal tumors. She's an oncologist, orthopedic oncologist, and then went out to Kansas to build a program there as a young attending, which is impressive in and of itself. Musculoskeletal oncology requires anatomic knowledge, requires problem solving, it requires teamwork. And those three things, I think, are the fundamental strengths that belong in academic medicine. She has a broad research and leadership. I'm not going to rehash her CV, but I can tell you she's received awards and participated in pretty much any of the alphabet soup organizations you can think of, including the Academy and AOA, the NBMA, the National Board of Medical Examiners, the American Medical Association, the Medical Association for Education at medical school level. So her interests travel from the very early part to the very late part of training, and of course, the late part of training, the ACGME. And you know what? Credentials are not what defines someone, really, in terms of why we put this special invitation to the best of the best, in our opinion, for the Frymoyer. There are some intangible qualities, I think, that we seek to recognize, and Kim Templeton definitely embodies those for us. So what sets her apart is a passion. It's a passion and response to knowledge, to asking not only the question why, which I think we all do, then going and setting about trying to answer that question. And I think you'll see that today. She's chosen to talk to us about, should we be looking for sex-based skeletal conditions? There's a why. I bet she tells us the why, and I bet she tells us exactly what she has personally done to set out to answer that question. So with no further ado, I will introduce Dr. Templeton and hand you the mic.
Thank you so much, Dr. Ames, for that kind introduction. I am humbled to be following in the footsteps of Mark Asher. He was the first faculty member that I met when I went to Kansas City to interview for a position, and was always a mentor of mine. His office was across the hall, so I would be there on Saturdays and Sundays, usually sometimes talking about patients, usually complaining about the state of the world and how we needed to fix it. So it was always, he was a very, very interesting person, and just again, I'm honored and humbled to be following in his footsteps. So should we be looking for sex-based differences in musculoskeletal conditions? As I mentioned to Dr. Ames earlier, this could be the shortest talk ever with one slide of yes, and then we're done. But really something that we need to look to in depth and to figure out how we do this, in addition to how we move the slides. So I showed this slide yesterday. I and others have been working on this for a long time. You see the date of this of 2004, where I was invited as a young investigator, so that was a really long time ago, to a symposium that the Academy was having to talk about sex and gender-based differences and how we approach them from a musculoskeletal perspective. There have been discussions within orthopedics and in medicine in general since that time. We've made some headway, but not a lot. So just a brief review of what are sex-based differences from the Institute of Medicine report, noting that every cell has a sex, so it's not just organ-based. As we discussed yesterday, sex is the defined by the Institute of Medicine as gonadal, but now defined as the genetic complement, whereas gender are social interactions, which allows you to see available resources, how people access the healthcare system, and what they have available to them. When we look at sex-based differences, it's more than what we refer to as bikini medicine, meaning it's more than breast disease, cardiac disease, and reproductive disorders. Unfortunately, when we talk about sex-based differences in other venues, people tend to focus on the reproductive health, but it's not. It's every area of medicine. It's every area of medicine because of sex-based differences in anatomy, physiology, especially the immune system, the local and systemic effects of sex hormones, and these, in addition to gender and emerging other areas, impact the incidence, presentation, response to treatment, and prevention of health conditions. However, it is a changing landscape. Because of the intersection of sex and gender, it can be difficult to determine what is a sex-based impact, what's a gender-based impact, especially with the emerging field of epigenetics, which can lead to changes in gene activity or express really seems to be the correlation between societal influences or gender and physiologic or anatomic or sex-based influences. So how are sex-based influences manifested, especially in musculoskeletal conditions? We know osteoporosis is more common in women than in men, but it still occurs in men. Women are more likely to develop osteoporosis as a result of loss of sex hormones in menopause. Men develop osteoporosis usually as a secondary condition to other chronic health conditions. In our study of distal radius fractures, we looked at differences between women and men after their fractures. Men were less likely to be tested for osteoporosis after they fractured, which is probably a gender-based issue, although sex-based from the perspective that sometimes people forget that men also get osteoporosis, so you just don't remember, you just don't test them. Interestingly, women had a longer fracture-free interval than did men if they were tested. So more likely to actually to have been treated once they fractured and were tested for osteoporosis. If you look at osteoporosis-related hip fractures, mortality among men is twice that of women within the first year, likely related to the fact that they tend to be older by the time they fracture, and they tend to have other health conditions, which is why they developed osteoporosis and fracture to begin with. As we discussed at length yesterday, differences in osteoarthritis more common among women in almost every joint. The gender or the sex-based gap is increasing over the years, and the sex-based gap increases with age. And then the comorbidities that you tend to see, you see in both women and men in terms of hypertension, COPD, et cetera, for people with OA, but those conditions are more common among women. The prevalence of each is more common among women, and women had a higher number of cumulative comorbidities. And does this reflect perhaps a common pathway in terms of an inflammatory response? And women experience musculoskeletal and back pain more frequently than do men. As we talked at length yesterday, there are a lot of reasons for that from both a sex and gender-based perspective. But perspective, women tend to have more conditions that lead to pain and have different nociceptive receptors in their brain and in their spinal cord. And we know that these differ early, even looking at neonates, you can see differences in EEGs between male and female neonates if they are subjected to a painful stimulus. So this is something that tends to be hardwired. What we don't know is what happens over time, especially with the influence of sex hormones. There have been multiple studies looking at pain in humans to try to see what the differences are, sex-based differences are in pain. These studies, though, are a little challenging to interpret because by and large, they use healthy young volunteers and then they subject them to a single source of pain, whether it's pressure or temperature or ischemia or whatever, and then see how they respond. It's a way to look at pain, but in my mind, it's a little bit challenging because I don't know how you extrapolate like a sensation of cold in a 25-year-old healthy patient to the 70-year-old female with knee pain. So if you look at these studies, the results are kind of all over the map that maybe women have more pain, maybe men have more pain. We don't know. The studies are just challenging to interpret. And then that gets back to the issues of gender and are there societal expectations that it's more okay for women to complain of pain, including in these circumstances. So pain is a bit challenging. And I do a lot of emphasis on pain because that's usually what we talk to with our patients. They present with pain. We ask them how they feel, ask them how much pain they have. It's just a huge part of what we do in orthopedics. And then getting to the gender differences in pain. So when you're looking at any of these studies, understanding that there are gender-based differences, which are societal, although those that we used to think were gender-based in terms of catastrophizing actually tend to be more sex-based. So why do we care about including sex-based differences in research? Well, it obviously impacts patient care. If you have a study that includes a group of people and you don't know who's in that group, hard to know what to do with that data when you're looking at a patient across the room and from you in clinic. It impacts education. Without data, you have nothing to inform medical student or any other healthcare professional education. It also doesn't help anywhere in terms of residency and continuing medical education. If you don't have data, you have nothing to teach. And it also impacts future research. We develop lines of research because of what's been researched in the past. If this isn't looked at, then like, how do we inform the next level of research? And helps us to move from the what in terms of just basic differences in incidence and prevalence to the why. Why is this happening? Because the why is what helps us in prevention and treatment efforts. This is not just an orthopedic issue, which I guess is good to know. This was, if you look at women with myocardial infarctions, they tend to present differently than do men and tend to have worse outcomes because they don't have classic symptoms. Women tend to present with fatigue, nausea, shortness of breath, rather than crushing substernal chest pain, since that's not the quote unquote classic presentation, meaning it's not the male presentation. They tend to often be diagnosed with anxiety and are less likely to be diagnosed with an MI. So the fact that sex-based differences are an issue is not just an orthopedic issue. This is across every condition that impacts both women and men. Why do we look, again, at sex-based differences? Why does this make a difference? Well, we know that at times women have worse outcomes after hip arthroplasty. This is a study looking at hip arthroplasty and found that women had a 29% higher risk of aseptic implant failure. If you're just looking at a group of people overall and you're looking at the failure rate of hip arthroplasty, you're not going to understand why they fail unless you look at specific things. And it doesn't just mean sex, it can be a multitude of things. You can look at their BMI, you can look at their social demographics, what do they have available to them in terms of resources. But part of this is looking at sex. Is there a reason based on sex that people are more likely to have implant failure? And they found that the implant failure rate was higher among women. So it's not just overall, there's an issue with women. Could be explained by the fact that women are smaller. So that's a sex-based anatomic issue. So you're using a smaller head size, and so it's more likely to dislocate. Could also be the fact that if you just exclude the metal and metal arthroplasties, women tend to have a higher failure rate. The thought being that this may be related to women's heightened inflammatory response. So you're putting more metal ions, you stimulate an inflammatory response, and you failure. If you look at metal in particular, again, women have a higher rate of failure due to likely the increased inflammatory response. This is a study from Josh Jacobs' lab at Rush, looking at those with continued pain after arthroplasty. First of all, women had more pain than did men. So again, it gets back to, is it because they're having something that causes more pain, or how their body is responding to pain, or how they're expressing their pain, but they're coming in with pain because that's what we see. Women had higher levels of pain. Among those that have pain, women were more likely than men to have higher levels of metal sensitization. So that is a sex-based thing. Perhaps if women are having issues after arthroplasty, perhaps that's because they're sensitized to the metal because of their higher inflammatory response. So again, this gets back to, it's not just looking at a group of patients, but separating them out based on sex to see if there are differences between the sexes. But if you then look more specifically, such as knee arthroplasty, this is a study we discussed yesterday. Again, you can look at knee arthroplasty, you can see a certain number of people continue to have issues with function, decreased quality of life, and pain. But which patients? So again, there are a lot of demographics that you can use, there are a lot of other factors you can look at, but one of them is sex and gender. So if you separate it out based on sex and then including gender in this, you find that women had worse outcomes or had worse quality of life, pain, and function coming into arthroplasty. They had more pain in more areas. They had higher levels of other conditions such as depression and anxiety. They did worse after arthroplasty. If you control for all of those factors, the sex-based differences tend to resolve. And so it's not that women do worse after arthroplasty. They do worse because they have specific things that lead them to doing worse after arthroplasty. again, you're not going to know that until you look, where that can impact things. Maybe we need to be addressing their pain, depression, and anxiety before arthroplasty so they have better outcomes. Maybe we need to be working with our internal medicine and primary care colleagues to get women into arthroplasty sooner, since women tend to delay because of societal gendered expectations to take care of everybody else first. But if you know that these are the factors for women in particular that lead them to having worse outcomes, then maybe there's a way that we can address that. But unless you're looking for sex-based differences, you won't necessarily pick that up. Again, it's an issue with medical education. If we don't have data, we don't have anything to teach. This was a survey of medical students across the country about their knowledge of sex and gender overall, not based on not just orthopedics, but overall on their medical education. So as you see, the vast majority were familiar with the topic of sex and gender medicine. They knew it improved their ability to take care of patients. They almost all thought that medical education should include teaching of this. Most, 2/3, understood the majority of medical knowledge is based on data obtained from males, but the concerning thing is just a little over half that their medical education includes teaching of sex and gender differences. That's not surprising because the curricula usually don't contain discussion of sex gender differences beyond what you see in terms of reproductive health. So I've worked for quite a while on this and trying to figure out how we get this information into medical education, understanding we need more research, but there's research there. So let's take what we have and get it into the curriculum at every level. And frequently the pushback is two things. One, we already teach it. And when you probe further, it's like, well, they have an OBGYN rotation. Awesome. What are they going to learn about osteoarthritis and ACL tears on an OBGYN rotation? So no, or MIs or anything else where women are different. The second is that there are no faculty development materials. That I will agree with, and that's something that we need to improve, because if faculty don't know that this thing exists out there and that ideally would be in the curriculum, they're probably not going to know how to teach it. So how do we direct people towards teaching materials? But again, to have those, we need to continue to improve our research and improve our data. This is not a new concept. This is, again, back in time when I started working on this 20 years ago. I was trying to see what was being taught, and so went through the curricular database at the AAMC to look at various conditions that you saw in orthopedics more commonly in women than men. So I looked for like domestic violence and ACL injuries and osteoarthritis and osteoporosis, and found almost nothing. Kept coming up with OBGYN topics. Doesn't mean they weren't being taught, but we couldn't find them logged anywhere in the AAMC system for any curriculum. I tried to review our own curriculum at our own institution and went for sex and gender. Unfortunately, he's a great guy, but one of our anatomy professors, his name is George Ender. So every time I was searching for gender, I kept getting George's courses. It's like, no, I don't need to know what George is teaching in terms of like thoracic anatomy. So that was a flail. It was a fail. But eventually we did a survey that was that I presented as a study at an academy meeting, just students at several institutions, like, what are you learning about women, musculoskeletal conditions that are more common among women? Interestingly, they knew a lot about osteoporosis, which is great, considering the incidence and prevalence and the issues with fractures. And they had learned that from internal medicine. They also knew a lot about ACL tears, but almost everyone who responded, they knew about an ACL tear is because either they'd had one or they knew somebody who'd had one, not because they'd ever been taught about ACL tears. When we looked at the other conditions that were more common among women in terms of musculoskeletal health, the responses were pretty abysmal. And even if they're going into primary care, you kind of need to know things about like shoulder instability and osteoarthritis, et cetera. So again, we've looked, and it's just, I would say we didn't know much then, and I'm not sure we've made a lot of progress since. Where else does the lack of sex-based data impact things? Well, it's in the development of clinical practice guidelines. Again, as I discussed yesterday, clinical practice guidelines are based on existing data. If there is no data in the literature, you're going to have nothing in which to develop guidelines. So we've been working on the ones for the academy in terms of pain management. This resulted in a review of about 70 articles. Almost none of them included sex or gender-based differences, other than for cognitive behavioral therapy. That's a bit of a challenge, which is why this disclaimer is at the beginning, with the resulting appropriate use criteria that was published in JOS earlier this year. There again, this is comment, this sort of like most Mike Kilroy was here, but when you see this is probably something I put in. It's worth repeating, clinician must consider the influence of comorbidities, including age, pre-existing opioid use, sex, and gender on the pain experience. And so this is just trying to reinforce that the guidelines are fine, but the guidelines are based on the data we have, which is not awesome. Where else in clinical practice guidelines? This is a review of clinical practice guidelines from the physical therapy world. Out of 36 guidelines, 5 incorporated sex and gender, and all but 1 talked about issues of pregnancy. So again, not the scope of sex and gender-based differences. Where else did the lack of data impact things? Also impacts issues with health policy. Ideally, health policy should be based on available data. When you're looking at health policy, though, again, if the data isn't there, you don't have anything on which to work. So this was a review that hopefully is going to be coming out soon. I sent in the revisions earlier this week, but we looked at all of the state opioid action plans to see who's talking about sex and gender, because got a whole lot of, there are areas in healthcare where we know that, especially in musculoskeletal conditions, where we know there's difference in incidence and prevalence. We don't know much beyond that. Pain is one where we actually have quite a bit of data. We know that there are sex and gender differences, again, in perception of pain. There are differences in opioid prescribing. Women tend to get significantly more opioids than do men, especially if they express signs of catastrophizing. Differences in opioid response. As I mentioned yesterday, women tend to have less response to opioids and have a slower time to onset, primarily because the drugs, at least we think, are addressing the mu receptor. Women are kappa opioid receptor dominant. So if it doesn't work, they're probably going to take more. Women have a higher risk of addiction. Something to remember if you're prescribing your women patients opioids. Women can undergo what's called a telescopic phenomenon, which means they become addicted at lower doses over shorter periods of time. But women also have decreased rates of accessing opioid use disorder treatment. OUD treatment is equally effective among men and women, but women access it at a lower rate because of societal gendered expectations. So again, taking care of everybody else first, and they don't access treatment, or they don't have childcare or whatever. So understanding that we know all of these differences between men and women in terms of pain, are those actually expressed in the state policies that are used to develop healthcare professional education about opioids, legislation about opioids, regulations, the impact of the legal system? Is that somewhere described? Going through the 49 states with plans, for some reason, Wyoming doesn't have a plan. I guess they don't have opioids, I don't know. But doesn't have a plan, but going through the other 49, most plans did not mention sex-based differences. Among those that did, almost all of them discussed this through the lens of neonatal opioid withdrawal syndrome, and among those, almost all discussed it through the perspective of the fetus or the neonate, not talking about the mother. So while we need better data in terms of sex and gender, even in an area like pain where we have a lot of data, it isn't always being consistently incorporated into the studies and into the policies where we need to use the data, but we can always use more data. And why do we need more sex and gender data, especially sex-based data? It's addressing issues with transgender health. It's obviously becoming more discussed more, it's becoming more of an issue. A significant proportion of the population, as you know, treated either with and or gonadotropin releasing hormone agonists to try to decrease limit development of their sex identified at birth, or gender affirming sex hormone therapy. But what we don't know are some of the musculoskeletal impacts of that. The data that we have is there tends to be a decreased bone mineral density among trans women, but you actually see that prior to any sort of hormonal manipulation. And we think that's related to diet and decreased exercise. There's decreased lean muscle, lean body mass among trans women at 12, but even more than 36 months after therapy. But we don't know what that means in terms of function, because there are really no studies that address athletic performance. You hear so much about the limitations on trans athletes being able to participate because it's unfair, especially for trans women. We really don't have any data on performance to document that. The data that's there, which is pretty slim, tends to be cross-sectional. It's not longitudinal. So we don't know how people change over time, and everybody's an individual. Everybody's going to be somewhat different. We don't know what their performance was when they came in. So we don't have longitudinal data. We also don't have data that assess for risks of injury. So what do hormones do? Obviously the sex-based anatomic differences aren't going to change, but what do hormones do to changes in ligamentous laxity? For a trans woman on estrogen, does that make maybe the ACL more lax and more higher risk of ACL injury? With there being probably some hormonal influence on neuromuscular control, what does that do in a trans athlete? Does that increase again the risk of injury? And can better understanding of sex and gender at baseline improve the knowledge of transgender health and vice versa? And so I do some work in the transgender world, and it's frustrating because we're always talking about transgender health. It's like, we don't understand sex and gender really well from a cisgender perspective. Trying to then work at a transgender perspective is kind of taking us above and beyond. First, we need to understand baseline and the cisgender world, and then I think move into transgender health. So what is the current status of reporting outcomes based on sex? So we know that we need more data, but part of it is the research being done, and second is the data being disaggregated based on sex, and is it being reported? So what do we have? Well, it depends on the question. If you do the split search I did for transgender patients and osteoarthritis, and if you think that there's not much on sports, there's nothing out there on osteoarthritis. So when you're looking at sex-based differences, depends on the question. If you look at animal models, as we discussed yesterday, use animal models of pain to try to disaggregate the impacts of sex versus gender. So with animals, it should primarily be sex, but most of the studies in animals are done on males. So that really doesn't help you define and better understand the sex versus gender impacts on pain. Human studies likewise have challenges. This was a review of randomized controlled trials done between 2004 and 2009 on topics of health conditions that impacted both men and women. So those that were a single sex condition, like gynecologic condition or like prostate cancer, whatever, that was not looked at in this study. If you looked at these, in 2004, 13% of studies reported differences based on sex. By 2009, it was 25%. And these are, journals like New England Journal of Medicine, JAMA, Annals of Internal Medicine. These are the heavy hitter journals, yet the data wasn't being consistently reported based on sex. So that's a decade ago. Certainly we've gotten better. Maybe not. This was an article that was published in Core in 2020, looking at 6 leading orthopedic journals, looking just at the year 2016, with more than 700 studies. More than half of the patients were women. Only a third of the studies reported data based on sex or gender. Of those that did, more than a third found a difference. So it's not as though if you don't look, it's not going to be there. There is a reason to look. You're going to find something. So even in the decade between looking at all the other health conditions to now, it was still only we've gotten better. It's gone from 10% to 30%, but it's still pretty low. This was the study that we did that was published in 2020. And what I wanted to do with this is look at not all orthopedic conditions overall, but look at one where we don't know if there's a difference, rotator cuff injuries, and one where we do, which is OA of the knee. Found that for both, about a third studies looked at sex-based differences without differences between the two. So as I mentioned yesterday, if you know that there's an area where you don't know if there's sex-based difference, you think you'd want to, or one where you know there is, you think you'd want to continue that research, but yet between the two, there was no difference. Was there a difference based on who wrote the paper? The question came up yesterday, is this something that women should be researching, and can men venture into this field? And I would say, yes, everybody, this is for something for everybody. We looked at the authors of this in articles that had reported results based on sex were more likely to have a woman as a first author or as a last author. If you just looked at last authors, they were also more likely to report differences based on sex. So the gender of the author of the article tends to make a difference. I think maybe because we talk about this more in the women's health community, and maybe women are more attuned to this, I don't know. And this is great because we need more women authors, but unfortunately only a small percentage of authors of orthopedic articles are women. And so if this is something where we're going to rely on women to do this, we're not going to move the field, because until we have more women authors, this may not be addressed. So this is an issue for everyone. So how do we address this? A variety of ways. One, the government has been involved for quite a while. There have been increasing demands for more attention to women's health. In '77, the FDA banned women of childbearing age from participating in most early phase clinical research trials because of the risk if they were potentially pregnant. This then led to most researchers not wanting to include women at all because of the risk to a fetus if they were pregnant, or the the issues with hormonal cycle, and that could potentially change results, which is not an awesome way of addressing research if you're excluding half of the population. So that edict from the FDA was reversed in 1993. And in '98, they said they would refuse to file any new drug application that didn't include enough women to assess safety and efficacy by sex. So at least the federal government agencies went from precluding women to wanting to actively include women. And then the most recent change has been the NIH SABV, or sex as a biologic variable policy, which states that the NIH expects that sex as a biologic variable will be factored into research designs, analyses, and reporting of vertebrate, animal, and human studies. And that's important because it's not just including, but it's reporting based on sex. So again, it gets into disaggregation of data. That went into effect in January of 2016. If you review NIH proposals submitted since that time, there's been significant increase in the consideration or mention of sex, or male and female, and man and women in NIH applications for both human and animal studies. So it has impacted that. There's been an increased inclusion of women in clinical trials because people are thinking, well, now we need to include women because we have to have women in our research proposals, so we need to recruit women. Although there are more women in clinical trials and more women being included in research, there are still issues with then reporting and disaggregating the data based on sex. And while this NIH policy is great, it probably isn't going to have a huge impact on the orthopedic community, because here that 5% of academic orthopedic surgeons receive NIH funding. So it's important to know, and frequently where the NIH goes, other funders will follow, but not yet. Other funders really aren't venturing into this area so far. And as we know, a lot of orthopedic research isn't funded at all. So it's good to have the funders involved. It raises the awareness, but from an orthopedic perspective, not clear that this is going to have a huge impact, again, because most of our research isn't funded. Next is, what are the role of IRBs if you're trying to get a study approved at your institution? Are the IRBs looking at this? And the answer right now is no. If you go to the CITI program, required education for IRB members, they have a module on diversity. But when you take the module on diversity, it's talking about gender diverse individuals, it's talking about race and ethnicity. All of that is extremely important, but it's not tackling the basic differences based on sex. It has nothing in there about sex-based differences. So I reached out to them to see if we can try to fix that. And so we put together a webinar that was held earlier this year talking about why sex matters, the role of research in IRBs in informing education and patient care. Really trying to see if we can get IRBs engaged in this, because that's at least one step. If IRBs are looking at studies about inclusion of sex and gender in study design, that may help where we go with research. So we talked about what are sex and gender, the impact of including or not including, where it is in medical education, and how we move forward, including sex in research, especially the role of IRBs in trying to impact this. And then what are the role of journals? There are currently several existing guidelines about the inclusion of both sex and gender in research, including orthopedic research. So lack of guidelines isn't the problem. We have plenty of guidelines. The question is who's doing what with the guidelines, and are they being enforced? The one that's used most commonly is what's called the SAGER guidelines, the Sex and Gender Equity in Research guideline that came out in 2016. And it basically states, for if you have a condition that impacts both women and men, then you have to have discussion you have to include both women and men in your study design. If you don't, you need to explain in the method sections why not, and discuss that as part of the limitation. So it's not a mandate that you include both women and men in the study. It's not a mandate that you disaggregate the data. As we talked yesterday, if the N is too small for either the man or women part of the data, you're going to end up with false negatives likely, and that's going to give you results that are telling you there's not a difference where there may be one. So it's not mandating that you disaggregate data, but it's just stating if you don't, you at least have to explain why, and an N that's too small is a perfectly reasonable explanation. There are also guidelines from the International Committee of Medical Journal Editors, Council of Science Editors, and AMA or JAMA guidelines. Council of Science Editors guidelines basically just reference the SAGER guidelines. The AMA guidelines for JAMA ask that you report the data based on sex or gender, except if it's a condition that only impacts one sex or gender. Some journals are really jumping on board with this. Last year, Nature put out a statement about raising the bar in sex and gender reporting and research, that when you're submitting an article to Nature or manuscript to Nature, you are going to be prompted at the time of submission to provide details on how sex and gender were incorporated in study design, which is great, but maybe a little too late if your study's already done. So that's why they put this out, so people are aware before they write their manuscript that they're going to be asking for that. Lancet Rheumatology, the year prior, also noted they're committed to addressing gender bias in research and reporting. So they are going to be looking for the inclusion of sex and gender as well as other demographics. Neither journal says that if you don't include it, they're not going to publish, but at least is a trigger to get people hopefully to think about this. The question though is, are journals the appropriate arbiter of this? And that is an argument that's going on now within several journals and within the research community. Do you actually want to get to the point where somebody is submitting a journal or an article to a journal and we're trying to figure out whether or not sex and gender has been included? Depends on what you're studying. So if it impacts both men and women, at least think about it, but journals may not be the ones to tell you whether or not you can publish. Depends on sample size. Again, if you don't have a sufficient N, it's not, you really don't want to look at this, and your a priori study goals, what are you looking for? Because the studies are not designed to ask about sex or gender differences, they're likely going to be underpowered. You could also end up with too many analyses with spurious significance, which is going to lead future researchers down the wrong path and give inaccurate information to clinicians. Want to be cautious about authors feeling like they're being pressured by journals to do sex and gender disaggregation, because if that's not how the study was powered or designed, going back post hoc to do this evaluation is probably not going to give you great data. Even though there are guidelines, enforcing them can be challenging. When is it relevant? What do you do with a great manuscript that comes through that doesn't disaggregate data based on sex? Are you going to turn it down just because of that? Or is this something that you at least want to mention somewhere in the manuscript? People who review for journals are volunteers. May not be aware of the need to look for sex-based differences. So this can lead to some inconsistencies in reviews. If you have some who are aware of this and pick it up and mention this in a review, but you have some who don't, how do you try to mesh those two? So you have inconsistent reviews. And again, by the time the manuscript is submitted, it's probably too late to then tell the investigators, I'm sorry, you didn't include this at the study design, do your study over. That's not going to work. So are there other roles for journals? Is it rather than turning down articles, at least reaching out to investigators to have the sort of discussion on what they anticipate? Because as I mentioned with the core article and our article about the percentage of articles that disaggregate data based on sex and gender, is there actually a right percentage? So if 30% is too low, how many do we want? But again, it depends on the question you're asking. So from a journal perspective, we're trying to come to a consensus. Back in the day, again, we had the meeting almost 20 years ago where we just talked about sex and gender. That was a great place to start. But currently what we're working on is really honing down on how do we actually improve this from a research and IRB and journal perspective. So this is a meeting that is coming up in Boston in November. That is being sponsored by JBJS and the NIH. And we're going to be talking about what sex and gender is, how it looks, what it looks like in other fields, what the SAGER guidelines are and how to implement them, what IRBs are doing and what journals can do. At this meeting, we've invited representatives from all the major musculoskeletal journals. I think we're up to about 30 journals so far that'll be participating, because we have this in the morning, but in the afternoon, we're going to have small group discussions to actually come up with an action plan on how we fix this and what is the role of journals versus IRBs, looking at sex and gender, but also looking at how do we factor in other demographics, how do we factor in the question from yesterday, how do we factor in issues from with articles that are coming from outside the US, understanding that cultures and therefore gender impacts are going to be different. But at least this is an attempt to get everybody around tables and talking about where we go next and how we improve this. How do we change things in terms of medical education? This was an article that we published last year looking at sex and gender-based health from a medical education perspective, defining, in our opinion, what health professionals should know how to do and what they should be able to do in terms of sex and gender. So at least identify sex and gender differences, identify their role in terms of risk of conditions, how they respond, how their impact on differences in treatment, how you address this in terms of healthcare policy. So at least these are guidelines that we can use. The other thing that we're working on is a project we're working on through the American Medical Women's Association is to come up with what we're calling fact sheets. So I talked about the lack of educational material. So we're coming out with sheets on various conditions. I'm doing the musculoskeletal stuff. And for musculoskeletal, we're going to have sheets on sports conditions as well as osteoarthritis. My role in this is, or my goal in this is actually twofold, because there should always be two uses for something you're doing. This is not only to improve their knowledge of sex and gender, but it's to get musculoskeletal education out there. So we can teach musculoskeletal education through sex and gender education. It's a way to try to get it both. But these are fact sheets that are primarily being developed by medical students. So the medical students go out, I talk to them about which conditions are common that they're going to be seeing in their patients. They go out and do the research. They come back to us, the faculty that are developing these, and we go through the fact sheets just to make sure that they're correct. And then the students take them back to their schools. So again, hopefully this will, for the students that are interested in sex and gender, they can learn a little bit about orthopedics and vice versa. But the next step, once we have this, is how do we incorporate this into graduate medical education? How do we ideally get this onto the ACGME resident fellow survey, which is going to be a goal if they're taught about sex-based differences? And then how do we get this included in CME? So lots of efforts, but we need more data, we need more research, because without that, there's no educational material. But we also need to be including the data that we already have. Other responses, there have been responses of organized medicine that they've been dipping their toe in the water on this. The AMA encouraged that medical and scientific journals require, when appropriate, sex-based analysis of data. This was I'm one of the Academy delegates to the AMA, and so this was a resolution that I had submitted defining an expanded definition of women's health, meaning getting us from reproductive health to sex gender differences. I started this because I got a little frustrated going to AMA meetings, hearing people going to the microphone saying that they're going to talk about women's health and hearing them to talk health, which is important, but it's not everything that is a sex or gender-based difference for everyone. And so their policy is recommending that journals publish data that's been. Also another resolution that the AMA will work on including this in medical education. So this is a report that came out of the resolution, again, talking about it's beyond reproductive biology, talking about the complications or the complexity of sex-based differences and application to care. And this is the article on AAOS Now if you want to know more details about this, but it's just talking about how we need to be including this research and in education. It was a little interesting getting this off of the ground because I was getting a lot of pushback, obviously, from OBGYN, because this isn't women's health, what kind of is, and it is sex and gender-based differences. I had a lot of support from the other academy and the other orthopedic delegates, because as soon as I started talking about osteoporosis and osteoarthritis and ACL injuries, it's like, yes, these are sex and gender-based differences. Then we got the cardiologist on board, which is what helped push this through. So the large bodies, the large medical organizations in the country are getting behind this. It's just how do we then at the grassroots level actually bring this to fruition? So in summary, improving health and health outcomes for everyone. requires a better understanding of the impacts of sex on health and disease, more than just incidence and prevalence. Incidence and prevalence is a great place to start and to know what to look at, but not what you're looking for. Unfortunately, research currently is inconsistent, including this variable in research design and reporting of results. As we talked yesterday, there are a couple of ways of doing this. One is looking at it as a primary outcome. So looking at sex is your primary goal of the study. But something that you're going to be able to do more of is a secondary look, where any study you're looking at, if you're including men and women, disaggregate data and look at differences between the two. Lack of including a reporting based on sex, lack of reporting based on sex complicates translating any outcomes to the bedside. So looking at like the Academy Clinical Practice Guidelines on pain, what do those do to help treat the pain for the patient that's in your office? Also can have negative consequences, like Ambien. And if they'd have tested that on more women, we probably wouldn't have had the issues with Ambien. Lack of sex-based data compares curricular updates and change for healthcare professionals at all levels of care, which then also complicates and impacts patient care. NIH funding requires inclusion of sex and gender in research proposals, but they can't impact this change alone, especially in orthopedics, where most of us don't get NIH funded research. We don't get funding at all. So funders, awesome to have them on board, but that alone isn't going to impact things. Journals have taken this on as a challenge, CORE probably being the primary example where they've taken this on, but we need to get more journals on board. And then given the critical impacts of IRBs on research, what is their role in their area? And that's still under discussion. Our discussion so far with, at least there's the CITI program, is can they adopt something similar to SAGER? Meaning when somebody's submitting a research proposal, talk about how sex and gender is going to be included, and if not, why not? Because if you can't include it, if the there's not enough data to disaggregate, that's fine, but you at least let your readers know that you thought about it and you looked. So what can we do? What are some of the action items? If you're a learner, if someone's talking about a case presentation and a man or a woman ask how could this condition present and what the differences in treatment and outcomes if it was somebody of the opposite sex or gender. If you're an educator, add information about sex-based differences to lectures, grant rounds, journal clubs, including where we don't know something. So if there's no data out there, that's perfectly appropriate, but in a lecture, we don't know the sex-based differences because you never know, there may be somebody in the audience that decides that they want to take that on as a research project. That's how the studies that you guys reviewed in Journal Club with are looking at the sex-based differences that came from our group, that came from somebody listening to a lecture about sex-based differences. Like, well, then that's a look. You never know who's going to find something in a lecture that they want to take on. If you're a researcher, does your study design include consideration of sex or gender differences and the appropriate study population? And once you've done, you have analyzed your data based on sex and gender, especially if it's been designed to look for that. If you're an IRB or IACUC member, are you reviewing proposed studies for inclusion of sex or gender differences? And do you know what that looks like? And how do we improve that? And if you interact with your institutional IRB, maybe contact them to see if this is something that they're interested in. If you review for journals, are you commenting when sex gender differences are not mentioned or addressed? Again, you can't ask the researchers to go back and redo their study, but at least if you mention that in their review, they may be willing to put that into their limitations if they didn't. And if the journals don't seem to consistently publish studies with sex and gender analyses, maybe worth reaching out to them, but hopefully we'll do this with our meeting later on this fall and see if we can try to fix that. So what can we do today? Include appropriate numbers of women and men in studies. If it's appropriate, if it's something that occurs in both women and men, and report those differences, reaching out to local IRBs and reaching out to journals to find out what their policies are, especially in terms of SAGER guidelines. So thank you very much. I appreciate it. Yes, sir.
Thank you for very good, informative, data-based discussion. I find refreshing in this area. One of the issues that I think comes up, and you pointed to it and then sort of became a problem, is the distinction between sex and gender. One being genetic, the other being social content.
Right.
You then proceeded to basically say sex, gender
Yes,
in everything.
yes, yes,
Those are totally different.
yes, they are. Yes, they are.
And based on your data, trans population is 0.6%,
Mhm.
which means that gender tracks with sex 99.4% of the time.
Right.
Why do you emphasize gender when in fact what you're really interested in is sex? I mean, I'm not saying that gender issues aren't important, not at all.
Right.
But what I'm saying is by throwing gender into it every time,
Yeah.
you're throwing up this huge red blanket that becomes this political nightmare.
Right.
Whereas the sex part of the discussion is really very straightforward.
No, I totally agree. And so I apologize for conflating the two. It just, usually we're talking about both sex and gender, understanding that both impact patients' health. But I think my hope would be if we can just get research designed and results disaggregated based on sex, we have made huge progress. We can get to gender later, but as you said, sex is much more clear cut. It's genetic. You know what you're dealing with. If we can just do that, that's going to make a huge difference in literature because even that is not being done well. So I would agree. I think gender is important to health, especially then when you look at epigenetics and maybe there's a lot of crosstalk between the two. But if we can start with something clean cut like, or at least relatively clean cut like sex, then yes, we've made progress. So I would agree.
Yeah, I mean, I think you're absolutely correct. And I think part of the resistance to what you're proposing is because sex and gender keep getting mentioned together.
Yes.
And I'm just curious, and if you don't want to answer that,
Yeah.
fine. Is there some pressure to include gender in this discussion when in fact your real issue is sex?
There's not pressure, but there's always this understanding that gender impacts health too, in terms of access to resources and your interactions with the healthcare system. So understanding that, look at rate of knee arthroplasty in women. Women have probably a greater need for knee arthroplasty but don't receive it at the rate you would anticipate to some degree because of societal gendered expectations on them and not seeking care and lower rates of referral. So gender does impact health. And so I think that's part of the pressure is that it is a sex-based issue, but gender impacts to some degree how the sex-based influences are being manifested or treated. So there's not pressure, but it's just understanding that both impact it. But I would agree again that if we're going to impact change, let's make it slightly easier and just focus on sex for now.
So I agree, but that's the reason why I made the point that gender tracks with sex, so that you don't have to separately identify gender as such. The same way 25 years ago, I remember someone's race when I was presenting the case. But race becomes a representative of a whole host of cultural, but we can at least start looking at race without having to worry about, all right, I don't know exactly what that means yet, but until we get the race piece of it down, we can't get to the next step. And that's really.
No, and I completely agree. So I think if we can just look at sex, that's going to take us light years beyond where we are now because so many journals or so many articles that are out there don't even do that and leave gender alone. Now, the thing with gender too is that it's that gender is becoming political and that gets a little bit dicey, but it's always trying to remind people that, when you're out there and they're talking about the politics of gender, that gender is a scientific term, it's not a political term, but yeah, it's getting used as such. I know, I try, that doesn't go over well, but I try.
Thank you very much. I think all of us in the room would agree that musculoskeletal education in medical school is very important. I'm one of the faculty that coordinates what we call our connections course, where the second year medical students get essentially 5 days of their medical or their musculoskeletal education. And one of the things that I think we've come across here is with the emphasis of DEI on medical education and things, we are almost told not to single groups out, including kind of these differences between men and, or, you know, male and female with certain things. So that's a bit of a hurdle for us, given that we know these things. And I think, you know, what you've been doing with, especially the last part with the fact sheets that you're having, you know, the medical school students come up with research and giving that so that it can be used in education and gives us, you know, some additional data to hopefully put more of that into our medical education. So that was just a comment, it really wasn't a question.
No, I appreciate that. And that's one of the things that I and others have been trying to do when we look at orthopedic or musculoskeletal education. Is there a way you can infuse that into whatever you're doing? And so again, looking at the fact sheet, so let's put some that has some musculoskeletal information. Is there a way that somehow you can try to get this into the curriculum? Because I would agree, it's pretty abysmal at some places.
Just a quick comment and question. I really appreciated that it made a lot of sense. You made a great case for the why of this, with every cell being different between male and female sex. And counter argument would be, you know, you could break down any group of people. But why don't we do every research study include, you know, redheads or short people? Or, you know, we do that with, you know, different characteristics of groups. But this is such a, you know, basically the population is different fundamentally, biologically in one way than the other. So that makes a great deal of sense. My question is, you know, it's a huge political thing. I think in medicine, we care about people. We want to take care of individuals and we want to take care of society. In my practice, I do total joints. I've taken care of a couple of transgender people recently, treating them just the same as anybody else, great outcomes just like anybody else. The thing that concerns me, and I see you're involved in kind of the bigger societies in medicine, is in our medical record, they're labeled as, so somebody who was a male who's turned into a woman now, has had the sex change operation, had the hormones at all, is now listed in our chart scientifically as a female. And so I just wonder, you know, how we use language and how one even does research now, when we are confused as to what was somebody's sex, what is their sex now, how are we documenting this? Can we, as a medical community, be very clear about how we are categorizing sex versus gender? Even when I'm looking at a patient chart,
No, that's a great point. And actually in studies looking at medical records, gender is not always terribly accurate, and that's a major issue. What we do at our institution is, as Liz, document the patient's sex and their gender, understanding again that they're going to be congruent for most, but not for everyone. So maybe an issue with joint replacement, or I've seen an issue is with patients with osteoporosis and low impact fractures, because, you know, if you're getting a DEXA, you're going to be using a male or female normative database. So if you have a transgender patient, it makes some difference whether or not they're using the database based on the sex or based on the gender. And I've had issues where I've talked to the technicians and talked to people in radiology. It's like, I know that this person is a woman, but their bone is male. So use the other database. Now, if you look at the recommendations from the Endocrine Society, they say, look at the database based on their gender. They know more about osteoporosis than I do, but I'm not convinced of that because I don't think your bones are going to change that fast. At least we don't have longitudinal data that demonstrates the impact on bone architecture and size with sex hormones. And in my mind, there probably isn't much. So yeah, so if there's a way that your medical record can just list both sex and gender, and at least we have it in our system, so you can look quickly. And so you're not looking for any sort of gender affirming surgery, because a lot of transgender people don't have gender affirming surgery. So just looking for that isn't useful. But if they can list both sex and gender in the record, it's easier to pick up.
Epic has a module called SOGI for sexual orientation and gender identity that's going to be initiated soon. And it's going to be, patients are going to be filling that out presumably. And so there'll be that sort of information within the electronic health record. So I believe, do you have Epic?
Yes, we do.
Yeah,
Yep.
do you use the SOGI
Mhm.
module?
Yes.
And so I think, we'll find it very helpful in that regard. Dr. Templeton, thank you so much
Thank you.
for such a stimulating talk that had more relevance to what we are. So I'd like to present you a token of your visit. And thanks so much once again.
Thank you so much.
You're
It was
welcome.
great. It was lovely meeting you too.
You can go over and do that again. Sure.